So I'm sure you've read my blurb, but I'm a emergency medicine doctor and pre-hospital care doctor. I work at Addenbrooke and with MAGPAS and with EHAAT. And I've also done a little bit of festival medicine here and there. And I'm a module lead for the QMUL BSc in pre-hospital care. And chose the topic of recreational drug toxidromes because I think it's an interesting topic and it's good. I think I'm looking at the chat, there's a lot of people who are paramedics and student paramedics, and just being able to kind of recognise patients and what they might have taken when they can't tell you might be quite helpful. So I hope you find this interesting and a little bit different to some of the other talks you might have had recently. So we're going to have a think about the toxidromes, but more with a recreational drug slant, and then we're going to think about the management of these. So first of all, I think we start by just clearing up what a toxidrome actually is. Let them sleep it off and just keeping a close eye on. And if I was going to give naloxone, I probably would just titrate smaller doses just to kind of try to avoid bring them too far out of it and causing problems for myself. So there's another question for you just regarding opiates. What if your patient's in cardiac arrest? What are people's thoughts on giving naloxone in cardiac arrest? Because it's a bit controversial.
So somebody's put post-ROSC. Yeah, give naloxone. It is one of the reversible causes, toxicity. Yeah, technically reversible cause, so I definitely would give it. Yep, give during ALS. Give it a go.
Yeah.
Yeah, if it's indicated in GL-CALC, then I'd probably give it. Yeah.
Lovely. Yeah. So it's there's not much evidence on this, and I was having a look at the evidence today as to whether during arrest and as such whether naloxone has any major effect. There was a few papers on it. This is one of them. This is from back in 2010. It looked at 32,000 ALS dispatches over a 4-year period. Interestingly, there was only 42 patients in that who were actual opioid-induced arrests. But what they did find, though, in around 70% of those, when they gave intra-arrest naloxone, there was a favourable change in the rhythm on the ECGs. They kind of hypothesised that it probably was beneficial to give in arrest. And this is what GR-CALC says. You may have seen this or not. There's a Q&A, and they again say lack of evidence, however, probably not again, it's a reversible cause, probably not a bad idea, but the main thing is obviously if you're in arrest to continue good quality BLS, ALS, and this is kind of a side stream. From personal experience, only a few days ago, I had a gentleman who had an overdose in heroin with an arrest, and we did give naloxone. We gave a lot of them. We ended up giving 6,400 micrograms in total in the end, and an attempt to revive him. Raising eyebrows and that kind of thing. So these are all things to look out for. And then just as interest, like you may know this, but cocaine used to be something that was found in Coca-Cola. That's where the name came from. It was in your tooth, because obviously it's an analgesic, and when they rub it into the gums, it makes it go numb. So it was used for like toothache and things like that as well. So yeah, so it's fascinating how things are used, and not too long ago. Crack cocaine. So I've not seen as much of this in the UK, but now again see some patients. Free-base form of cocaine, usually smoke, can be injected, and it's cocaine that's converted to crack, and they use like baking soda and a teaspoon of tea light, and the bicarbonate reacts to the hydrochloride of the powder cocaine, and it makes like the free base and the carbonic acid, and then you can get this free base layer that separates in this oily layer, which is then dried and rolls into like a rock. And then they smoke it, they kind of put it in, they smoke it, and it reaches the brain within 8 seconds. So it's a really, really quick onset. It has some pretty devastating effects. Probably all heard of crack lung. Certainly seen a few patients with crack lung in my time, and you can see these quite tragic pictures to the left, people kind of before and afters, after kind of getting hooked on crack cocaine. So it's not a nice drug at all, really. So I'm going to move on to a different one now. So you've got another pre-alert, and this is for 2 patients found outside a nightclub. And when you arrive, pre-hospital on the day, they are comatose. Some of them maintain their own airway. Respiratory rate's kind of normal. Bradycardic, hypotensive. Pupils are full, mid-sized, and reactive, and they appear a little bit dry, and they look at their skin. What do you think? What kind of toxidrome do you think this could be?
So we've got somebody said that looks like my ID card from my F2 consultant. Ketamine, spice.
Very good, very good.
Oh dear.
Mine too, to be fair.
Synthetic cannabinoid, synthetic in nature, synthetic. Yeah, some good answers there.
Lovely. So I can't see them. Yeah, so this relates, for, as you kind of said, like, sedative hypnotic toxidrome. It's quite similar in some ways to the opioid toxidrome, but similar but different. But certainly people who are abusing benzodiazepines, barbiturates, GHB, liquid ecstasy, GBL, that kind of stuff, and spice as well. So they're kind of all classed within this toxidrome. Oh.
Changing experience I've ever had in my life. There were scary parts, foreboding parts. I always knew there was beautiful and joy and peace on the other side of it. It was freeing. It was really freeing.
This is Alana. She's describing what she felt after she took a dose of this stuff, psilocybin. It's a naturally occurring psychedelic compound, the kind that you find in magic mushrooms. But she wasn't tripping in a dorm room or a Woodstock. It actually wasn't recreational at all.
If anything became unreal, or I was feeling nervous or not in touch with reality, I would squeeze his hand and he would squeeze mine back just to reassure me that I was okay and everything was all right.
It was part of a controlled medical test to see if psychedelics could be useful in helping people quit cigarettes. Alana had been smoking for 37 years before her session with psilocybin, and she hasn't had a cigarette since. Research on psychedelics for medical use is preliminary. Most studies suffer from really small sample sizes, and that's partly because the federal government lists LSD and psilocybin as Schedule I drugs. So researchers face extra red tape, and funding is really hard to come by. Vox writer Herman Lopez reviewed dozens of studies that have been done, and he found that psychedelics show promise for treating addiction, OCD, anxiety, and in some cases, depression. One small study of 15 smokers found that 80% were able to abstain from smoking for 6 months after a psilocybin treatment. In a pilot study of 12 advanced cancer patients suffering from end-of-life anxiety, participants who took psilocybin generally showed lower scores on a test of depression. And a smaller study suggested that psilocybin treatment could actually help people with alcohol dependence cut back on their drinking days. We don't have all the answers as to what exactly these treatments are doing in the brain, but they seem to work by providing a meaningful and even mystical experience that leads to lasting changes in a patient's life.
The issues that I talked about or thought about or went into during my experience were transformative in the sense that I got to look at them through a different lens.
I know it sounds weird. I feel like I have more connections in my brain that I couldn't access before.
That feeling that Alana is describing is actually pretty spot on. When you take LSD, your brain looks something like this. You can actually see a higher degree of connectivity between various parts of the brain. It's not limited to the visual cortex. This communication inside the brain helps explain visual hallucinations, and the researchers argue that it could also explain why psychedelics can help people overcome serious mental issues. They wrote that you can think of psychiatric disorders as the brain being entrenched in pathology. Harmful patterns become automated and hard to change, and that's what can make things like anxiety and addiction and depression very hard to treat.
The reason that those kinds of conditions are so difficult to treat is that there's something more to them than just the illness.
That's Albert Garcia Ramu. He's a Johns Hopkins researcher who's worked on studies of psilocybin and smoking addiction, like the one that Alana's involved with. He says that when participants take psychedelics,
they have a very profound meaning